Good morning and welcome to the EHJ Today 2016 in Rome. My name is Julia Steli. I'm a cardiologist at the University Hospital in Zurich. Joining me here today are Roxana Meron, interventional cardiologist, professor and director of interventional cardiology research and clinical trials at the Mount Sinai Hospital in New York, and Peter Kapitein, heart surgeon and professor at the Erasmus Medical Center in Rotterdam. Peter, let's start with you. We can say that there's been a shift from surgical procedure to percutaneous interventions in the last years, especially for heart valve disease. Would you still encourage young doctors to specialize in heart surgery? And will these young doctors still have enough overall exposure and workload to gain a sound level of expertise?
Yeah, well, actually, it's a very, of course, relevant question at the moment. TAVI has shown great results. And therefore people expect that there will be less surgical aortic valve replacements in the coming years and more transcatheter valve replacements. At the same time, what we have experienced now is that the number of surgical aortic valve procedures has not decreased so much. We originally did 240 aortic valves per year and we're now at 230, 225. So you would have expected a much steeper decrease than what we have seen. So it might be that there are more patients referred, and so there's still, let's say, enough volume for young doctors to train on surgical aortic valve replacement. At the same time, you also recognize that it's very important with transcatheter heart valves that surgeons are involved with the procedures. And not so much because they have a certain expertise that interventional cardiology don't have, but if you want to bring the field further, and if you want to, let's say, try new techniques, often, you need a surgeon as a backup in a lot of procedures, and so you want surgeons also to know what the ins and outs are of transcatheter heart valve implantation. And I also have one resident at the moment who's very eager to learn transcatheter heart valve techniques. He says, well, this is the future. So I want to become a surgeon, but I also want to learn how to use wires, how to implant those valves. And I think so at a certain moment you can have at the table one interventional cardiologist and one surgeon that does the procedure.
Yeah, that's a very interesting point. If you had to tell them now how the job description of a heart surgeon will look like in 10 years, I mean, would it still be the traditional heart surgeon, or will we be looking like at a hybrid operator with interventional skills?
Yeah, I think so. My opinion is that we have to specialize further. So you would have a surgeon that is more dedicated to valve interventions. And it could be either surgery or transcatheter heart valve interventions. So I think that's my dream, how it would. So we also have to change our residency programs to allow them to spend hours or days in the cath lab. On the other hand, I have a colleague who always says a little bit provocative. He says, I'm too good to play with wires. I mean, I'm trained to be a surgeon, I'm trained to do a mitral valve repair, and that is a completely different set of skills than, using wires and implanting a transcatheter heart valve. So why would I need to learn that? Let me stick with my surgical skills and let me do the surgery, and there will still be cases with complications after transcatheter valve implantation. Maybe, a valve that starts failing and has to be replaced with a surgical heart valve. And let me focus on that technique instead of learning a technique that is actually better suited for the cardiologist who has much more knowledge about the wires and the skills, etc. So there are two schools. I'm more in the one that is saying, well, as a surgeon we should be involved. Because, for example, if we go to the mitral space, you may still need surgeons to do a transapical procedure. And so therefore, if you would just be an interventional cardiologist, you may lack that set of skills that you need for those procedures.
Roxana, let's say that the current development, as Peter said, will lead to heart surgeons specializing to a greater degree in percutaneous interventions. Will you think that at one point they could even replace the traditional interventional cardiologists?
So it's a great question, and I think that interventionalists as a whole are extremely welcoming and embracing our surgeons very, very much into the field. And I think that there will be in the future a combination of heart team specialists that will include physicians with skills on the interventional side as well as the art of a surgeon, the skills of a surgeon. I think let's not minimize the baseline training that gets you to that specialized way. The surgeons get, in the United States, 5 years of general surgical training where they are working in and understanding how to treat, not just in the operating room, but before, during, and after. Those are skills that just don't come up. We need to kind of think about a cardiologist and what we went through in our training that's very different than how surgeons look at this. So I think in the end, we're going to need both skills, and the patient is going to be better off because we will be working together in pursuit of the same goal, the best outcome for the patient. So I'm not concerned at all. Actually, I think it's a great step forward.
Okay, let's speak a bit more about this concept of a heart team or a heart center, where like heart surgeon and cardiologists, they treat the same diseases in similar patients. What is the main task of a heart team, and how does that work in real life?
So this whole concept came about when Peter, who is a leading executive committee member and a principal investigator of the Syntax study. It started back then when we realized that if you're going to look at a patient with multi-vessel disease, you really do need the opinions of a surgeon as well as an interventionalist or a cardiologist who's going to really make important decisions. I think what we're looking at is not just in the operating room or in the theater, but more importantly, again, in evaluation of the patient, making sure that they are having the appropriate procedure for their appropriate condition, for the condition they present with. And I think that the way I see it is that the future lies in us working together and, again, expanding on each other's skills and learning. I can't tell you how much I learn from just being with our surgical colleagues and having those meetings, those discussions, and the kinds of things that they know that we don't know, and vice versa. So I do believe is a tremendous, fantastic next step for the future.
Yeah, interesting. Peter, you mentioned it before. Would it perhaps make sense to establish rotations for heart surgeons in interventional cardiology and vice versa in the curriculum of both fellowships, like to improve the understanding of both discipline and nurture a closer collaboration?
Absolutely. So currently we have our training program is 6 years. It's only 1 year general surgery, and to allow more time to subspecialize. So at the last year of your training, you can choose to go to the cath lab, for example, and spend half a year in the cath lab to train with the interventional cardiologist. Or somebody else may say, well, I want to go into the direction of congenital heart surgery, and then they can spend last year or last half year in congenital surgery. So it allows now to go to the interventional lab and to learn those techniques. I think that's important. We have to change that program where it's very rigid. You have to do the 6 years of surgery and then, then you can choose. No, I think you already have to start earlier.
Yeah, interesting. Let's hope that this will spread over the world. Yeah. Roxana, again to you. In recent years, we have witnessed TAVI shifting from inoperable to high-risk patients, and meanwhile, the FDA has approved it for also intermediate-risk patients. Do you think it can become the default procedure for severe aortic stenosis, irrespective of surgical risk? And if so, for what kind of patient categories will surgery still remain the therapy of choice?
So a great question, and it's kind of like looking at the glass ball and trying to predict the future. And I think that the fact that we're moving into the risk category, coming down into the low risk, and as you know, there are now multiple low risk studies that are ongoing to evaluate the safety and efficacy of this procedure in even the low risk population. And I really believe, especially in the female patient population, and we're hoping to do something together with Peter in that a first line of therapy, having this treatment might be sort of what we're looking at in the future, a lesser invasive yet durable procedure. And that second piece, the durability, is incredibly important. So before we say that this will replace surgical aortic valve replacement, we have to be sure that the durability stands the test of time for what the surgeons have been able to do with the surgical aortic valve replacement for all of the years that that has been in the past. So the durability still is a very, very important issue. Now, having said that, you can always say, well, the first line, why do we care about durability? Because the first line of therapy for the next 5 years or 10 years could be a TAVR or TAVI, and then we can go on. Well, we don't know what is the effect of surgical aortic valve replacement on a prior TAVR patient. How is that aorta looking? What is that? What does it mean for the surgeon? Are there going to be new skills for the surgeon to learn to replace and take out that implantable device and replace it with a ring or what have you? How does that work with a? And it's a big question, and I think we're gonna this is gonna be the future.
Yeah, absolutely.
Isn't that right?
Yes.
Peter?
Yeah, you're absolutely right. So the durability might be an issue, especially for the younger ones. I think for the elderly patients, it doesn't matter that much because they want to be out of the hospital fast and a fast recovery. So I think it's as you said, only for the younger ones it might be. I think for the intermediate high-risk patients, there's no doubt that TAVI will replace surgical aortic valve replacement.
Well, let's look at the AQUA registry, which was recently published at the European Heart Journal. It suggested that the outcome of TAVI is similar in hospitals with and without on-site heart surgery. How do you interpret this data, and would you be concerned about TAVI being also executed in hospitals without high volume academic background?
Of course, let's say the complication rate nowadays is so low that you don't need a surgeon in most of the cases. So if you want to establish whether it is really non-inferior, you need a large sample size. If I would be the patient, or if my family member would be the patient, I would always say go to a site where they have surgery, because if something happens, they can maybe help. It's very exceptional, but if you don't have it, there's no way that you can save a patient. Sometimes you still have a major complication with transcatheter heart valve implantation, and it's nice to have a surgeon on site. And of course, in the majority of cases, it goes fine. But I think it's still important to have, especially also the discussion to choose which therapy. So the heart team approach.
But I think as skills improve, as the devices improve, and we go to a lower profile devices with really easy, efficient deliverability, and it is going to come to that point. It's got to think about the STEMI situation where or a PCI without surgical backup in the early days. And this is really, we have to remember, this is the early days of TAVI or TAVR. Even though it's 10 years in the making, it really does take that much time to develop that.
Okay, thank you very much for this interesting interview. Thank you.
Thank you very much.